The organizing committee for the kind invitation, and I'm really very happy to be here with a lot of good, eminent ophthalmology teachers and very dear colleagues. I will be talking about Myoring extrusion in consecutive patients in Sudan we have experienced. As you know, keratoconus is very prevalent in our region. Almost we see thin corneas in half of the patients coming for refractive surgery, and out of these numbers, a lot of them prove to be keratoconic patients. For that, we have tried to provide treatment for that inside our country, because most of eye patients going outside Sudan for treatment nowadays are keratoconus patients. We are able to provide the Myoring system with the manual pocket maker. First of all, I don't have financial interest, as shown. And the Myoring, as you know, is a continuous, flexible, 360 degrees full ring of different sizes. It is implanted in an intrastromal pocket. That pocket, or the Myoring, will reshape and stabilize keratoconus corneas, as you know. It achieves both visual rehabilitation and it stops progression of the disease even without cross-linking. We are using manual pocket maker to make a 9mm diameter intrastromal pocket, 300 microns deep, and as you know, Myoring is implanted through a side 5mm incision. Alternatively, of course, as you know, we can do that using femto laser, and there is debate which can make better pocket. The manufacturers of this device, they claim their pocket is better, but in the literature there is still some debate. Here is a video showing the procedure. We fix a suction and then we put the appanator and simply we do the pocket. It is very easy and very quick surgery. But there is some worry because intraocular pressure will be raised for very high level during this part of the procedure. And the centration at the end will be according to the corneal reflex. Now we are centering the ring according to the corneal reflex while instructing the patient to look at the light of the microscope. Post-operatively, we can see the ring in place using corneal OCT. The nomogram we are using is very simple. There is 4 sizes, and we use that according to the K readings. The outcome used to be very good, and we could improve up to 9 lines in average, and the improvement continues both in K readings and in uncorrected visual acuity. Quality of life also, we have assessed quality of life for the patients who underwent this procedure, and it was good comparing pre-operative and post-operative quality of life. And we have published that in our local ophthalmology journal. As I said, there is a lot of debate regarding Myoring pocket making using manual method or the femtosecond method. Also, there is debate comparing Myoring versus corneal signals. And I have read a lot of topics in that, but here I am providing what was published by Muhammad Husni et al., and almost the results are the same. But in these patients, only femtolaser was used to create the pocket and the tunnels. As I said, we have seen extrusion of consecutive patients undergoing Myoring. One patient was extruded spontaneously, and another 5 were consecutive in very short time, and that was a very alarming condition for us. So we have stopped performing Myoring implantation and started to look for the cause. We have consulted the manufacturing company, and we have shipped back the instrument to them for check and calibration. And unfortunately, this was the cause. The tip was damaged of the diamond knife of the pocket maker. Actually, we examined it under the surgical microscope before each operation. But this is the photo from under the microscope, and you cannot detect the minor defect. And the company advised to use a laboratory microscope to detect these defects. But we have used another way. We take a photo by a mobile telephone, and then we magnify it, and that will show us very quickly and very safely, because to take the Israeli instrument in different sites will carry the hazard of contamination. But there was another astonishment. The outcome of the patients who were explanted or had extrusion, the mean K did not return to the preoperative readings. Most of the 6 cases had K readings less than the preoperative. They continued to have K readings less than the preoperative K readings. And also the uncorrected visual acuity did not go back to preoperative visual acuity. And we have suggested offering keratoplasty for some patients, but all of them refused to go for keratoplasty, and they said they are satisfied. Of course, we did not follow them for a long time, only for 1 month, but we are following them still, and we will see and report the progress of that and provide the needed help if some patient needs it. So that was a surprise for us, but was a good surprise for us and for the patients. And thank you very much.